about varicella infection in pregnancy. So just a recap, varicella infection, it's more commonly regarded as childhood infection, but due to immunocompromised state in pregnancy, and there is reducing herd immunity in the society, this predisposes our pregnant women to elevated risk of the infection. Now, primary infection can still be very significant in adults, and occasionally it causes devastating outcomes. Let's look at the epidemiology and immunology of this infection. So incidence has been reported about 3 in 1,000 pregnancies in the UK and about 5 in 1,000 in North America. Unfortunately, we do not have the data for Southeast Asia or even Malaysia, but given that we are a tropical country, we would assume that the incidence is way higher than this. Now, we know that it is a highly contagious infection, but the risk of transmission from shingles itself, which is not the primary infection, but shingles itself, it's about 20% of that of the primary varicella infection, and it occurs especially in individuals with disseminated zoster or localized zoster in immunosuppressed individuals. Again, like what Dr. Leong has mentioned, immunity is achieved via natural infection or vaccination. And unfortunately, the varicella vaccination is not recommended in pregnancy, being a live attenuated vaccine. So let me walk you through the agenda of my talk today. You have a pregnant lady here who is a kindergarten teacher, and her student has recently been diagnosed with chickenpox infection. So now, these are the questions that I would say run through your mind when this lady comes to your unit or your clinic. So number one, you would want to ask yourself, was her exposure significant? Second question would be, would she require post-exposure prophylaxis? If so, what are her options? Third, can she be monitored as an outpatient, or does she need inpatient management? Does she need treatment at all? What are her risks of associated complications? And finally, we'll talk about primary prevention. Now let's go through the first question. Was her exposure significant? So how do we define significant exposure? We know the transmission is via droplet and direct contact, and significant exposure is defined as being in a small room for more than 15 minutes with the infected person, or if your patient has got face-to-face direct communication with the infected person, or being in a large ward setting with the infected person, and obviously if she has had direct contact with the infected patient. And that comes to our second question. If her exposure was significant, does she require post-exposure prophylaxis? So I have come up with a flow chart. If you have a patient with exposure, it's important to check their immunity status first. So how do we do that? Is via asking two questions to them. Number one, has she had past natural exposure? That means, has she had infection in the past? Or has she had the varicella vaccination in the past? If her answer to any of these questions is a yes, then she can be reassured that her pregnancy is going to go fine without the primary infection, a varicella infection in pregnancy. Unfortunately, if her answers to both the questions is a no or unsure, then we would suggest to screen for her varicella IgG. And if this comes back as positive, again, she can be reassured. But otherwise, if this comes as negative, she would need post-exposure prophylaxis, and we certainly would recommend for postpartum vaccination. So bear in mind, in the absence of post-exposure prophylaxis, risk of developing varicella infection is about 72%. So that is really high, and hence the importance of post-exposure prophylaxis. So now let's talk about the options she has. So traditionally, the international guideline, which includes this guideline, the RCOG Green Top Guideline on Chickenpox in Pregnancy, recommend the immunoglobulin. But now with the recent study and latest evidence, the UK Health Security Agency has came out with the guideline, which was published just recently in January 23 on post-exposure prophylaxis for chickenpox. And they strongly recommend now that post-exposure prophylaxis, the choice of treatment should be acyclovir. So let's talk about these two different options we have. The varicella immunoglobulin is to prevent and attenuate the replication process, and also to reduce the risk of development of fetal varicella syndrome. It is effective up to 10 days after exposure, and the efficacy ranges about 40 to 50%. Women should be treated as potentially infectious from 8 to 28 days after receiving the immunoglobulin. So if you could recall from Dr. Leong, the incubation period is actually up to 21 days, but if they would have received the immunoglobulin, then they should be treated as potentially infectious up till 28 days instead of 21. And this, at this moment, when acyclovir is the choice of prophylaxis, we still can give the IVIG to patients with known contraindication taking acyclovir, such as those with known allergy or advanced renal disorder or renal or malabsorption. Recommendation also is to re-administer this varicella immunoglobulin for patients with repeat exposure if 3 weeks have lapsed since their last dose. So where did all these recommendation, what does all this recommendation based on? It's actually based on previous papers published like as early as 1974, such as these by Dr. James McGregor, which identify the significance of this contagious infection and the significance of having susceptible pregnant women to receive post-exposure prophylaxis. And they've noted that varicella zoster immunoglobulin actually helps to reduce the incidence of development of primary infection in pregnant ladies. And 3 decades later, international guidelines still recommend immunoglobulin as secondary prevention because it reduces the risk of congenital varicella syndrome. And in fact, the CDC and prevention task actually still recommend in the past, for IVIG to be given for patient who is susceptible to the infection. And this would reduce the risk of the incidence and the severity of the infection itself. Now, again, the RCOG guideline as well, it's stated nicely here that if a woman is not immune to varicella virus and has had a significant exposure, she should be offered the varicella immunoglobulin, and this would be effective up till 10 days. And if she has had a repeat exposure, a second dose will need to be given if it has lapsed 3 weeks after the last dose. Now, what's the problem with and again, this is another evidence by the Danish group looking into post-exposure treatment with varicella immunoglobulin, and they have found that there were fewer women who acquired that infection, and the risk of developing pneumonia is lower with IVIG. Now, this is the era before acyclovir was recommended. Now, what is the problem with IVIG? We know that there is no benefit in women who have developed rashes. And being a blood product, there is always risk of allergic and anaphylactic reaction and also blood-borne infection. And again, being a blood product, because IVIG obviously is extracted from patients who have had that infection and then developed the immunoglobulin. Being a blood product, the cost is very high. So all these factors has led to the exploration of other options, which is acyclovir. Traditionally, we would say acyclovir is not licensed for use in pregnancy, but so far there is no evidence to show harm to either the mother or the fetus with use of acyclovir, and I will show you the evidence later. It is an oral medication, and therefore we would think that patient would be more compliant to it. It can be given in outpatient setting, and it's readily available as compared to IVIG, where the patient has to be admitted or at least in daycare setting in overseas, and most of the time it's only available in tertiary center. Now, this is what I have mentioned earlier, the safety profile of acyclovir in pregnancy. So this is a paper published on the use of acyclovir, valacyclovir, and famciclovir in first trimester of pregnancy and looking into the risk of birth defect. We know first trimester is where organogenesis occur, and therefore the risk of birth defect is highest in exposure to any medication or any investigation. And from this paper, they have concluded that exposure to acyclovir in first trimester itself actually is not associated with increased risk of major birth defect. And hence, the UK Teratology Information Service has came out with this information and this recommendation stating that overall, acyclovir use in pregnancy is not associated with increased birth defect or preterm labor. Therefore, it is considered safe to be used in pregnancy. And after knowing that it is safe in pregnancy, now it's important to compare the effectiveness of acyclovir in preventing maternal chickenpox as compared to the varicella immunoglobulin. So this is a paper published on that subject, and the authors concluded that the findings support the use of oral acyclovir as first-line prophylaxis in pregnant women exposed to varicella, as they suggest its effectiveness. It's either equal, if not better, than immunoglobulin itself. However, there's a caveat here because the study only looked into the prevention of maternal chickenpox, hence there's limited data on prevention for fetal varicella syndrome. And based on this information and this evidence, the UK Health and Security Agency came up with a guideline like we discussed earlier. And in the guideline, they strongly recommend the use of acyclovir as first-line treatment for post-exposure women to reduce the risk of varicella infection. And the dose is oral acyclovir 800 milligram 4 times a day from day 7 to day 14 after exposure. Now, one may ask why day 7 and why not start on day 0 or day 1 itself? So this is based on a study on healthy children when they actually compared when acyclovir was given on day 0 and day 7 after exposure. And the study found that the incidence and the severity of varicella infection was significantly higher in those given acyclovir on day 0 as compared to those given on day 7. Hence the recommendation to prescribe on day 7 for 7 days. Now, what about repeat exposure after acyclovir? So you have a patient who has completed the course of acyclovir and now has come back to you and report on a repeat exposure. So we know that acyclovir has a very short half-life, and therefore guideline recommends for reassessment after second exposure, especially to check on serum immunoglobulin G to look for seroconversion. And if IgG is negative, they would recommend to re-administer oral antiviral from day 7 of second exposure. All right, so let's go to our third question. Can she be monitored as outpatient? Because it's important for patient to know whether she has to be admitted or not. So post-exposure, we would strongly advise for self-isolation. And during self-isolation, they should monitor their clinical signs of the infection. In the absence of varicella infection, they can be strongly recommended for postpartum vaccination. And in the presence of clinical signs, they should immediately report to their primary healthcare. So yes, in the absence of clinical infection, you certainly can just monitor as outpatient until they report to you if they have developed any new clinical signs of the infection. So what are the criteria for inpatient management? If you have a patient who develops symptoms suggestive of respiratory problem, neurological problem, patient develop hemorrhagic rash, patient with numerous mucocutaneous lesions, so less than 50 is considered mild, anything above 150 is severe. So you would want to monitor those with moderate to severe mucocutaneous lesion. If they have persistent fever, if you have immunosuppressed individuals, those who are taking immunosuppressive drugs, and particularly in our setting, logistic issue, because many women may not be able to self-isolate themselves from their young ones, or if they have immunocompromised individual at home, then you may want to consider for inpatient management. So does she require treatment? So now your patient has got clinical varicella infection, You want to know whether she has acyclovir initiated earlier. If she does not, we should give them oral acyclovir 800 milligram 5 times a day for 7 days. If they have had acyclovir in the past, remember that was prophylactic dose and it was 4 times a day. Now you need to give them a new course of oral acyclovir 5 times a day for 7 days. So this is nicely written in the RCOG Green Top Guideline on chickenpox in pregnancy. Oral acyclovir should be prescribed for pregnant women with chickenpox if they present within 24 hours of the onset of rash and if they are 20 weeks of gestation or beyond. But bear in mind, in real clinical setting, many of the patients actually come to you like after 24 hours or day 2 or day 3. And in fact, diagnosis most of the time is made on day 2 to day 3 of infection. Hence, because most of our pregnant ladies are immunocompromised, pregnancy itself is an immunocompromised state, we would still recommend to prescribe and to offer oral acyclovir if they come to you after 24 weeks and if they come to you before 20 weeks, because like what we've discussed earlier, oral acyclovir is safe to be prescribed in first trimester of the pregnancy. All right. And what are her risk of associative complications? Now, varicella infection-associated complications can be divided into maternal, fetal, and neonatal. Let's talk about maternal first. So the maternal infection includes pneumonia, which is most commonly seen. It occurs about 10 to 20% of the time, with a high mortality of up to 14%. Next, we have meningoencephalitis, like what Dr. Leong have discussed earlier. Fulminant hepatitis, as well discussed in Dr. Leong's case. Hemorrhagic rash and superimposed skin infection, and all these can predispose and can lead to severe sepsis. Another 2 points that I would like to highlight here is we would try to avoid NSAID's prescription and offering patient NSAID when patient has varicella infection due to elevated risk of severe skin and soft tissue infection associated with NSAID and varicella infection itself. Although I know most of us do not prescribe NSAID in pregnancy, but it's actually still considered safe before 28 weeks if it's indicated. Also to avoid aspirin, as aspirin or salicylate is associated with risk of Reye syndrome in varicella infection, and Reye syndrome, it's severe brain impairment, brain infection, and also hepatic infection as well. So if you have a patient with complications such as pneumonia, meningitis, hemorrhagic rash, or sepsis, we would advise for admission. In fact, she would warrant MDT management, ICU care, ID consult, and like what Dr. Leong has mentioned earlier, the oral acyclovir now has to change to IV acyclovir for 7 to 10 days, depending whether they are immunocompetent or immunocompromised patient, and antibiotics to be added for those with superimposed infection. Now, whether your patient has developed complication or not, as long as you have a patient who acquired or who contracted varicella infection in pregnancy, we would recommend for fetal scan. So detailed scan can be done at 20 weeks if your patient has had varicella infection in early first trimester or 5 weeks after their varicella infection, not just to look into the features suggestive of congenital varicella infection, but also to monitor the fetal growth. And I will tell you why. So next, next would be the fetal complication, which is a fetal varicella syndrome. The incidence was quoted, like what Dr. Leong has said, 0.2 to 2%, and it's highest risk when the mother acquired infection at 8 to 20 weeks. In fact, it's at 13 to 20 weeks, which predisposed the fetus to highest risk of fetal varicella syndrome. After 20 weeks, the fetus would be able to mount its own immunity. Therefore, fetal varicella syndrome is seldom seen after 20 weeks. Also because organogenesis happens in the first trimester. After that, it is less likely that the baby is going to have fetal varicella syndrome. Guideline would recommend for amniocentesis for PCR tests. Main reason being PCR test has got very good negative predictive value, but unfortunately, quite poor positive predictive value, and it's not routinely done in our setting. And those mothers with shingles are at negligible risk of having their fetal varicella syndrome in their pregnancy. So what are the clinical features of fetal varicella syndrome? most of us know, and most commonly known, is obviously skin scarring, skin lesion. It's usually according to dermatome distribution. Neurological damage such as cortical atrophy, spinal atrophy, microcephaly, and this baby after born may have or may develop seizure, microphthalmia, cataract, chorioretinitis, limb hypoplasia or other skeletal abnormality, and fetal growth restriction. Therefore, you need to monitor the baby's growth. What about varicella of the newborn? If the mother acquired infection within 4 weeks prior to delivery, the risk to the newborn is 50% newborn infection. And highest risk occur if the mother has rash 5 days before or 2 days after delivery, and this may lead to fulminant varicella infection. And hence, the guideline recommendation is to offer IVIG to newborn when the mother developed rash within a week before and after delivery. So traditionally, the incidence of neonatal mortality has been quoted to 30%, but fortunately now with improved health care and readily available immunoglobulin, the risk has now reduced to 7%. Now, this is a pictogram illustration that I've managed to extract from a European epidemiological review on varicella zoster virus prevalence among pregnant women. And it's nicely depicted here, the risk of development of fetal varicella syndrome and newborn sequelae based on exposure to varicella virus in each trimester. What about timing and mode of delivery? We would recommend to avoid delivery for at least 7 days after onset of rash. That is to allow passive immunoglobulin to the fetus, provided postponing delivery does not pose additional risk to the mother or to the baby. Mode of anesthesia, there is no contraindication for regional anesthesia as long as it can be sited at a lesion-free site. Mode of delivery would be dictated by obstetric indication. There is no strong evidence to suggest vaginal or cesarean section to reduce the incidence of varicella infection to the newborn. And finally, we come to primary prevention. So obviously, when we talk about primary prevention, the most important thing here is vaccination. So pre-pregnancy vaccination and post-pregnancy vaccination is important. As we know, during pregnancy, a live attenuated viral vaccination is not recommended. Now, if you have a patient who's now pregnant, it's important to screen for their immune status at booking. Obviously, we are not asking for universal screening for IgG, but at least what we can do is ask a few questions like if they have previous natural infection or if they have had vaccination. And if they are non-immune, strongly recommend them to avoid contact. Identify high-risk group, such as those who are not suitable for vaccination, the immunocompromised patient, and like you and me, those who are exposed to occupational hazard. Let's look at the high-risk group more detailedly. High-risk group include immunocompromised patient or immunodeficient individuals, those who are taking high-dose steroids more than 20 milligrams per day. So remember, we have many patients, those who are taking steroids, such as those those with autoimmune problem or those with post-transplant who requires steroid as well. Those on immunosuppressive therapy, again, patients who are post-transplant and patients who are on immunosuppressive medication like azathioprine or tacrolimus because of underlying medical comorbidities. Patients infected by retroviral infection. And lastly, we talk about postpartum vaccination, which is really important and would like to stress for patients who are non-immune individual to get their postpartum vaccination. It is a 2-dose vaccination given 4 weeks apart. Strongly recommend to avoid conception 4 weeks post-vaccination, and mother may be able to continue breastfeed to their newborn because the vaccination itself, the vaccine component does not excrete into breast milk, and therefore there is no problem in breastfeeding. 2 points I would like to highlight here. Patients who have recently received varicella vaccine within 3 weeks should not receive the varicella immunoglobulin. and patient who has recently received immunoglobulin, IM immunoglobulin for 3 months earlier, or IV immunoglobulin 9 months earlier, should not receive the vaccine. So vaccine should be given after that. So I have come to the last slides, which is take-home messages. Important, acyclovir is safe for use in pregnancy, hence post-exposure prophylaxis or treatment, it can be used in pregnancy. When it comes to post-exposure prophylaxis, acyclovir or varicella, both are safe in pregnancy, but based on the latest guideline, latest recommendation, acyclovir should be your first choice, being at the advantage of lower cost, more readily available, better compliance, and it can be served as in outpatient setting. And although guidelines say you should prescribe acyclovir if patient comes to you within 24 hours, we would still strongly recommend to prescribe the treatment, although your patient comes after 24 hours. And remember, the highest risk of developing associative complication is actually in 3rd trimester. So if you have a patient who is non-immune and who's in 3rd trimester, remember to advise them to avoid contact. Re-administration of post-exposure prophylaxis is important in repeat exposure. So don't think that this patient has had post-exposure prophylaxis in the past and therefore they do not require a second re-administration of prophylaxis. Prevention is paramount, both primary and secondary. Again, primary, it's prevention and avoid contact. Secondary would be your acyclovir. Varicella vaccination is not recommended in pregnancy. Hence, you should always check for their immune status at booking and counsel accordingly. And postpartum vaccination is highly recommended in non-immune patients, and it is not contraindicated for breastfeeding mother. With that, I conclude my presentation. Thank you. And these are my references.